This webinar series is really a chance to kind of look at innovative studies in population and health, and we're very excited about today's. The topic today is big data analysis on a shoestring using publicly available data for population and global health research. As we all know, we're seeing more and more research in demography and global health that's using big data, and it's been an exciting time when you think of all the possibilities that big data presents. But issues like cost and technical expertise required to work with big data have limited their use to date. As many of you know, PRB published a population bulletin last year called Demystifying Big Data in Demography and Global Health, in collaboration with Emmanuel Latouze from the Data Pop Alliance. We've since received questions from folks about how they might be able to take advantage of big data in their analysis without breaking the bank, investing in supercomputers, or hiring an army of data scientists. Today, we're very pleased to be joined by three researchers who have done some relatively low-cost studies and are willing to share their experiences with us. Doctors Cuervo, Wilde, and Alburez-Gutierrez have all used big data available from Google and examined important topics like equity in access to emergency healthcare, trends in fertility, and excess mortality during the COVID pandemic. So with their help, we're pleased to have this opportunity to further demystify and break down big data analysis for you today. We'll do each of the three presentations. We'd ask you to hold most of your questions until the question and answer period with Toshiko Kaneda, Senior Demographer at PRB, will be hosting. But if you have a question for clarification at the end of each of the presentations, please feel free to ask. But again, only questions for clarification. We'd like to save the broader discussion for once all three presentations have been done. And I'll introduce each speaker at the beginning of their presentation, so you don't have to remember all of the data about them after your brain is full of what all has been happening in each presentation. Our first speaker today is Dr. Luis Gabriel Cuervo. Dr. Cuervo is an experienced public health professional with over 30 years of contributions to global health. He's a family physician and clinical epidemiologist and has been involved in developing health policies, advancing social innovation and knowledge translation platforms, and setting norms and standards to increase the value of health research. He's been affiliated with PAHO since 2005, where he currently serves as a senior advisor on research for health. However, in today's presentation, Dr. Cuervo is not representing PAHO. Instead, he is sharing the results of his own doctoral research dissertation, the Amore Project. Currently a doctoral candidate in biomedical research methodology and public health at the Autonomous University of Barcelona, Dr. Cuervo will discuss how his participatory project integrated data from publicly available sources, such as Google Travel Times, household data from Colombia's census, and a National Registry of Health Services. He will explain how his project measured accessibility while accounting for traffic congestion with an equity perspective and proposed policy options to improve and monitor accessibility. Dr. Cuervo.
Well, thank you very much, Jeffrey. So I'm going to begin the projection here. I hope you can see the slides all right. Well, I found last year's bulletin on demystifying big data most inspiring. That was very, very helpful. And I'm very honored to be presenting today to this Population Reference Bureau webinar. It's a new audience for me. I want to acknowledge Toshiko Kaneda for her invitation and guidance, and Corretti Parmo for her support with logistics, our moderator, Jeffrey, and Lori Ashford. And I'm delighted to be joined today by Joshua Wilde and Diego Alburez. Let me begin by introducing the team. This is a collaborative project, and the lead people in the collaborative project are visible here in this screen. And I'm going to dive now into what the project is about, and that's mentioned in the introduction. This slide I'll project it at the end. If you want to scan the QR code or go to the webpage, and we'll put it later in the chat, you'll find the platform that we have produced, and you'll find all the publications and the methodological information, which is not going to be the main focus of my presentation today. So there you can find information, and also in a Padlet where we have provided all those kind of outputs of the research and the protocol and so on. But the key thing for us was that we noticed that the current methods of measuring travel times to health services do not consider important factors such as traffic congestion and equity. They are cumbersome and fail to involve stakeholders. Additionally, accessibility studies are complex and challenging for non-specialists to interpret. And we wondered why, if I need to go to a service or a hospital, for example, I can put it now in Google Maps, or I can put it in Waze or TomTom and find my way and know how long it's going to take me to get there. But when it comes to health services planning and land use, the information that's been used in most of the world is static. So you cannot have those kind of considerations looking into equity or travel times. So we theorized that accessible, reliable data to measure and optimize accessibility with an equity perspective could be drawn from publicly available sources, because we use them all the time in planning our own daily activities. We tested whether healthcare services accessibility could be efficiently measured using publicly available data. That's what we decided to do. And we tested in a city. Out of convenience, we picked Cali, which is one of the busiest, the most congested cities in South America. And it's a city that has 2.25 million inhabitants in Colombia, in the western part of Colombia. And you can see here how the population is distributed. The darker shades are the areas of the city traffic analysis zones, something that I would have not known as a public health person, but because we were working in a multi-stakeholder environment. Our group has people from very many different disciplines. We had experts in mobility that brought out that knowledge to us. And we have here the shades showing where the population is denser. So most of the population lives in the outlying areas of the city. As you can see here in the map, about half of the population lives in low-income housing, about 40% in middle-income housing, about 9% live in high-income housing, including the people that are domestic workers. So that gives you an idea of the city we were going to study. And the first thing we did to put this team together and do this work on a shoestring budget was inspiring other people to join us and contribute to the collaborative project. Because our focus was on social appropriation of knowledge, we brought on board the people that would be using the data from the outset and in the design of the platform and its development. So this is just a screenshot of an animation. It's a 4-minute animation that tells what is that we want to do. And it's available not just in YouTube, but in the Padlets and links I provided to you. And through 28 different interviews with groups of stakeholders, we also got the engagement of 36 people that are part of the collaborative project. The people in blue are the management of the project. The people in purple are co-authors of research reports. And the people in green are experts in different fields of knowledge that have contributed to this. And those constitute the current project. So I was mentioning that the usual assessments for accessibility that we have in cities are static. And we looked at 3 different scenarios in our test case. And one of those was accessibility to tertiary care emergency services. And luckily enough, we had in 2017 an assessment done for the city of Cali. And you can see here where the hospitals for tertiary care emergency services are located. They are towards the west of the city. And you can figure out here that the people that are further away are 20 to 25 minutes away from the services. But as anybody in a busy city would know, in a congested city, it might take a very different time at 2 o'clock in the morning and at 8 o'clock in the morning. So that's one thing that we were wondering, well, how does this work throughout the day? So that's the importance of having a dynamic assessment. So if you look at what we did, when we integrated information of the health services with the population and the travel times, is that the maps look very much alike. But that is when you have a free flow of traffic. That's not all the time. If you look at what happens as traffic builds up, this is 2 o'clock in the morning, and as traffic starts building up 5 o'clock in the morning and so on, you can see the traffic levels here increasing. It goes all the way to 9, which is peak traffic. and 8 in Cali is the mode, because it's a very busy city. And look what happened here. You see, just 1/3 of the population, or about 40% of the population is making it to the services within 15 minutes. So this completely changed, and they don't look alike at all now. It's 37% of the population makes it to a tertiary care emergency service. And if we actually look into the population density, you'll figure out very quickly that services are far away from where most of the population is. You see this kind of valley here, that's where the services are, and the population lives in the outlying areas of the city, and they're being far away. So that's why more than 60% of the population is in areas beyond 15 minutes of travel time to an emergency service. In this case, sorry, in this map, I'm using hemodialysis, but that happens with the 3 examples that we tested. It changes very little. And we also provided the information using simple descriptive statistics. So in addition to those visual maps that most people would understand if they know the city, you can find here that for 15 minutes of travel time in emergency services, which is the example I'm showing here, with traffic level 9, so we clustered traffic in different levels. 9 is peak traffic. This is how the distribution goes here for socioeconomic stratum. In Colombia, stratum 1 is the lowest income, and stratum 6 is the highest. And you can see that there's a huge inequity here, with mid-high and high-income people having access of over 80%, and the lowest income, about 8% of people have access within 15 minutes. You can see how that also happens with the education level, which of course is related to income, and with ethnicity. So you can see here that the Afro-descendants and Palenque people fare much worse than other ethnic groups. You can look into the different age groups and marital status and so on to have, let's say, an equity perspective. So this tells us what the situation in the city is. If you want to go into the methodology, it's published, the protocol is there, and there's also 2 other papers talking about methodology. Our main sources of information, we use the adjusted data for the census. We use the microdata of the Colombian census of 2018, adjusted to 2020, because those measurements were done in 2020. We did 2 measurements, one in July, one in November, each one for a week. And the changes between those could be well explained because traffic restrictions were put in place because of the pandemic. We use the traffic analysis zones. We use the data from a specialized registry by the Ministry of Health that has all the health services already digitized. And we use the Google Distance Matrix API for travel times. That was all integrated in our platform, and we ended up with 2 products. First, as measurements of accessibility for the entire city for the 3 case scenarios that we picked, that I'll show you in a minute. And then models for improvement. What would happen if we had services in a sector or 2 sectors of the city that optimize accessibility? So let's look into that. First of all, the microdata from the census is just a screenshot to show you that that's all digitized, and then we matched it to the traffic analysis zones after adjusting for intercensal growth, migration, and missing data. This is the adjustment. We did a random duplication of registries, and so we have that way the adjusted census. This is how the interface looks. Anybody can go and download this information, and you have the code for the city if you want to have the urban area or the metropolitan area. This is the urban area of Cali. And then we looked into each of the traffic analysis zones, identified the geographic centroid, and then adjusted by population, because population is not homogeneously distributed in each of the traffic analysis zones. There could be a park or something, and the population could be skewed. We made sure that this was within the borders or the nearest place to the border, because the forms are regular. And with that, we also brought on top of it, let's say, we integrated it with the information of the services, which was brought from the Ministry of Health's special database. In this example, I'm looking here into hemodialysis, and it brings down the 11 services for hemodialysis in urban Cali. So we used 3 examples. Tertiary care emergency care, this is the one that matched the example at the beginning. hemodialysis, which is a service that people have to use repeatedly, at least 3 to 5 times during a week when they have terminal renal failure. So it's regularly used by people, and each trip has a cost. So it's important because it can bring families into diving into poverty just because of the indirect and direct costs of having to go to treatment. And similarly with radiation therapy. So we're talking about 30 services, but those 30 services are located in 15 traffic analysis zones. So there is an efficiency on looking at more services in a city where services are all kind of clustered in a section of the city. As part of the sampling, instead of looking at each hour or each minute, which would make the sampling extremely expensive for the travel times, we used the K-means to cluster travel times and found these 9 distinct groups. And these 9 distinct groups go from 1, which is free flow traffic, to 9, which is peak traffic. And Cali is a very busy city, so 8 is what you have most of the day hours. So we moved from 168 hours of the week to 9 clusters, and we did 2 weeks sampling. We had 507 traffic analysis zones instead of 15,000 blocks, which is what the census would give us. And we ended up with 15 traffic analysis on destinations instead of 30. So by doing that kind of data modeling, we went from having to take 43.1 million data points to actually having to measure only 68,500 data points for a week. That means that the cost of sampling went from $3.45 million, because it's cents per data download, to $5,500 roughly for the data downloads for a week. And that information you can find in a publication in BMJ Open. Then we looked into also what would happen if you add services, as I was mentioning, whether it's one service or service in 2 different sectors of the city. And what you can find is, in this example for hemodialysis here for November, how things went from 69%, which was the accessibility in November for that service, to basically 97% by adding services in 2 sectors of the city. Look at what happened here to the socioeconomic stratum. It leveled. There's no inequity anymore, and the same for ethnic groups and so on. So you can assess the impact also in terms of equity. So I'm going to devote my last minute and a half just to mention what was it like. Well, I think multi-stakeholder collaboration was what made this possible, because each group of people, whether it's what the experts in mobility, in geography, in urbanism, in public health, brought different ideas of how we could measure or improve things more efficiently. The data analysis was improved. Data sciences, I would say, was kind of the cross-cutting element that helps us a lot. In terms of the use of Google data, we were able to bring the cost down substantially, and there's different sources other than Google that we could have used. For the examples, we use travel by car because it's the most commonly used in Cali for these services, and it was a test case where you were just trying to prove that it could be done. And the costs involved, well, our project wasn't funded, so we worked through the data downloads. We used crowdsourcing. We had a large group of contributors that were passionate about it. And our main investments were in communications so that we could share the idea and communicate the findings, and in publishing the results so that they were in open access. And basically that's what I wanted to share with you, and I'll be happy to elaborate at the question time. You can screen here, and that's all I wanted to say for now. Thank you very much.
Thank you, Dr. Cuervo. Fascinating. And I look forward to seeing that in comparison to the other 2 presentations that we have coming up. So we will move forward. Our second presentation is by Dr. Joshua Wilde. Dr. Wilde is a research scientist jointly in the Laboratory of Fertility and Wellbeing at the Max Planck Institute for Demography Research and at Portland State University. His research is in the field of demography, demographic economics, and development economics, with an emphasis on the causes and economic effects of fertility change at both the micro and macro levels. Dr. Wilde currently serves as an editor of the Population and Development Review, and also co-chairs the IUSSP panel on COVID, fertility, and the family. He was recently awarded a grant from the European Research Council to lead the Sex Ratio Project, which aims to study the determinants of natural sex ratios at birth. Dr. Wilde received his PhD in economics from Brown, and today he will present research that used data from Google on pregnancy-related searches to predict the COVID-19 pandemic's effect on birth rates in the United States. Thank you, Dr. Wilde.
Thanks. Sorry, it took me a second to get, is this looking good? Everything good with the presentation?
Yes.
Okay, great, perfect. So thank you very much for inviting me to come and present at this webinar. I'm very excited to be here, even though it was it is slightly early on the west coast of the US, and even more early because of daylight savings. But I'm going to talk today about a project that I wrote, as Jeff mentioned, on COVID-19 and using Google data to predict the effect of the COVID-19 pandemic on fertility. Importantly, though, I'm going to talk about it in the context of using Google data. So I'm going to spend a bit of time talking about, how we got the data and how easy it is to use, and how, you really can do Google data research using Google search data on a shoestring. It doesn't take a lot of time or effort or resources to use. I'd like to acknowledge my co-authors here who, helped invaluably here. Mostly they were people with me at the Max Planck Institute, which is also where Diego is. But, some people have moved on to different places. Okay, so this inspiration for this project was that at the very beginning of the COVID-19 pandemic, nobody really knew what the effect of the pandemic on birth rates was going to be. Initially, you got a lot of media articles saying, well, as couples spend more time in lockdown together, there's going to be a whole bunch of babies conceived, which kind of made for fun articles, and it was a little silly. But most demographers didn't think that was going to happen. They thought the opposite, actually, that there was going to be a baby bust. Because who wants to have babies in the middle of a pandemic with all the uncertainty going on surrounding both health and the economy and all these other factors? There was also discussion around possibly different effects among different types of pregnancies and maybe for different regions of the world. So, for example, in low and middle income countries, people were worried about disruptions to the health system, meaning that maybe family planning resources and contraception would be disrupted, so there would be more unintended births. Where in high income countries, people were talking more about potentially the planned births were going to go down. So there's a lot of uncertainty around what was going to happen. And so our idea was maybe we can use Google data to make a prediction about what's going to happen before it actually happened. So this paper was actually written well before 9 months after the pandemic, and we actually predicted in a way the future using this Google data. And we had this idea, but to be honest, we weren't the first team to use Google data to kind of predict the future, or at least nowcast the future. So there have been all sorts of applications where Google search data has been used to figure out what's going on in certain with certain variables. So the most famous example, I think, is Google Flu, where they were able to kind of nowcast and pinpoint flu outbreaks in real time using searches for flu symptoms. This is way before the pandemic. And then they expanded that to dengue, and then, mental health, suicide, well-being, all sorts of other public health variables have been predicted or nowcast using Google data. And when it comes to demographic outcomes, the same. So the three main pillars of demography, migration, mortality, and fertility have all been predicted or forecast using Google search data, as well as other things related to demography, such as sexual behavior. So to get into the data before I actually tell you about the project, because I think the data is really what this webinar is about, I want to show you exactly how we got this Google data and how simple it is. So all you have to do is you go, as a says on the screen, to trends.google.com and click on the Explore button. And it's going to bring up an interface that looks like this. So I don't know if you can see my cursor, but I'm circling the top left box where the word pregnancy is. You can search for any term you want here. So if there's some public health intervention that you want to see how people are searching for it, just type it into that box and you can see the volume. You can specify a geographic region, such as the United States, as in this example. And you can also specify a time frame. So in this example, I'm looking at the last 5 years. And the blue line is the graph of how this search happened over time. So for example, the pandemic, if you can see my cursor, I'm not sure if you can, was this little blip right here. So you see that there was a small reduction in searches for pregnancy as a search term around the time of the pandemic, but it wasn't actually that pronounced. So once you have your search and your time frame and your geographic location, all you have to do is click on this little icon, this downward arrow with the little bracket underneath it, and it will download a CSV file with the data behind this graph straight onto your computer. This is all free. You could do it right now, immediately. And for some paper, if you have 40 searches you want to do, you just do this 40 times and then you have your data and you're done. Doesn't take any research assistance, there's no funding needed. You can just do this. So I'm really happy that Google has allowed this to be put online because it's a great resource for using this kind of big data on a shoestring. Okay, so what did we do in this paper? Well, we just used simple data on birth counts from the CDC, and the subset of the CDC that has this is the National Center for Health Statistics. And that's free and available online. So we just downloaded the different, the searches, or not the searches, but the birth counts by state, by month, from 2004 to December 2019. And then we just linked that with the Google Trends data that I've just described. So we looked at monthly data for each US state from January 2004 to the present. The reason we chose January 2004 is because that's when the Google data starts. We would have, if it existed before, we would have used it before, but that's when the data is available from. And so I'm not going to get too much into the methods because I think the methods here are not that important. It's the data that we care about here. But basically, we had a prediction model based off of just a simple regression. And this model basically is going to correlate the searches for these pregnancy-related words to births at some future point. So for example, we may want to look at births 9 months later if we think that searches for something related to conceptions are happening. Or if it's something that happens in the middle of pregnancy, like a miscarriage, maybe we want to look 5 months later. So different time frames, different searches at different time frames could have different effects. And we include this all into one big prediction model based on a linear regression. Once we found these associations, we realized that just because two variables are associated doesn't mean that they're causally linked or that they're even predictive. So then we're going to use some more technical methods like machine learning to select out the most predictive of the words, of all the words that we tested. And then once we know the most predictive words from this machine learning method, the final step is to use the associations for the most predictive words to actually predict births in the future. So here's the initial keyword set. I don't have time in this presentation to talk about every single one, but you can see that we're looking for kind of general sets of words in large types of pregnancy-related groups, like searches that might have to do with unplanned pregnancies, or planned pregnancies, pregnancy intention, or pregnancy symptoms like morning sickness, for example, and some other variables related to contraception or unemployment, things that may affect fertility that aren't necessarily words having to do with pregnancy. So the first step, just finding these simple associations. Here's a graph that we included in the paper that shows the association between searches for the word clear blue and births at some future point. So for those of you who don't know, Clear Blue is the name of a popular pregnancy test brand in the United States and in many other countries. But since this focused on the United States, we focused on things that were popular in the US. And the vertical axis is the size of the effect, the predicted association. And the horizontal axis is months before birth. So for example, T-9 is 9 months before birth, which is about the time of conception. So as you can see, for the months before T-9, there's really no relationship between searches for clear blue and births at a later date. But once we get into the time frame of early pregnancy, particular T-8, right, the first month after conception, when women might be starting to learn that they're pregnant, all of a sudden we see that there's these significant associations with searches for clear blue and births 8 months in the future. And the positive association continues throughout the first and even into the second trimester of pregnancy. So, 2 or 3 or even 4 months after conception occurs, there's still some women searching for clear blue, apparently, based on these results. Same with the word for pregnancy. We have a lot of these words that all 40 words are in the paper, but I'm just pulling out some selected ones. So searches for Google searches that include the word pregnancy also follow a similar pattern. Here, I think the strongest association is about 7 months before birth. So women are finding out in the first trimester that they're pregnant, and they go online and they search up pregnancy, and then those increased searches are associated with increased births later on. The last one we're going to look at is actually medical abortion, or medication abortion, as sometimes they're known. Those are actually also positively associated with births in the future, which seems slightly counterintuitive, because you may think that if women are searching more for medical abortions, then there would be less births in the future. But we think what's happening is that if women search for medication abortions, that means that there's a lot of conceptions. And only some fraction of those women who search for medication abortions are actually having them. So really, searches for medical abortions are a proxy for conceptions, which is why they're positively associated. So you can do this for any number of sexual and reproductive health outcomes. I actually have a PhD student she's from Ecuador, and she wants to focus on abortion in Latin America. And she's looking at searches for abortion terms as part of her PhD in Latin America as part of her PhD project to kind of monitor demand for abortion. Okay, so the second step that I mentioned is we have to kind of validate or make sure that the words that we selected or these associations are actually predictive. And so we're using machine learning. So here we have kind of like the 7 most predictive words from this machine learning algorithm. And there are things that you might expect. So we have clear blue on there as number 2, but number 1 is unemployment, because there's a strong association between unemployment rates and fertility. And other words, I won't go into them, but that's the list. And the final step is to take the predictive associations, the ones that I just talked about, and then back when we were writing the paper in like April and May of 2020, we were looking at those searches in April and May, and we're saying, okay, if they're associated this way, then that means in November, in the future, when we expect the pandemic to actually affect births, this is our prediction of how the births are going to play out. So we use the associations we found using past data to predict future births based on our current estimation of the rate of conceptions. And here's what our prediction was. So this is a figure we have in the paper. So we showed that births were going to fall in the United States. We predicted about a 10% decline in births, with the peak being, or not the peak, but the lowest number of births being in March 2021. So how did it do? It did. So we made this prediction before we knew what was going to happen. So it was, a lot of times when you are writing a research paper, you want to be really sure that you're right. But this was kind of a scary paper to write because we were predicting something that was going to happen in the future. So we kind of, had to make a claim and predict something, and then people could tell us if we were wrong on the future. So it was a little bit scary of a paper to write. And it did. There were hits and misses. So the red line here is the prediction that you just saw in the previous graph. And the blue and green lines are different ways to measure the effect or the actual number of births that occurred. And as you can see, there were some hits, but there were some misses. So the size of the decline and the month where the decline was the largest were about the same, but were not able to pick up on early declines. And there was also a faster rebound than we predicted. Now, again, we're focusing on the data here, but there's a lot of discussion within the academic demography community as to why fertility actually declined way before it was predicted to. So for example, births started falling almost in July or August of 2020, which if you count 9 months backward, is way too early for it to be conceptions from the pandemic. So there's a big academic debate as to why that happened. And the model that we used did not account for this. We just said, what's going to be the effect of the pandemic? We didn't even take into account the fact that things could be falling earlier. So anyways, that's less about data, but it's just kind of an interesting thing for people to think about. So in the last minute or two, let me talk about things to think about in regards to the Google data. So the data that you get free from the website is standardized. They don't show you the actual number of downloads, of searches, but they standardize it between 1 and 100, where 100 is the highest volume time period. You can actually request the actual number of searches from Google, but you have to fill out a form, and they are kind of known for not being super responsive. So I requested that at the very beginning of writing this paper 3 years ago. I still haven't gotten a response from them, but I know other people who have. So it's kind of hit and miss. So you can get the data for free without any interaction with Google, but there's also the possibility of getting more, but you might have to bug them a little bit. Data is suppressed for low volume searches, which is kind of problematic. So if you're looking at very specific geographic regions or very short timeframes, Google might just give you a missing value. So we actually tried to redo this for sub-Saharan Africa because we wanted to see if, there was going to be an increase in births in sub-Saharan Africa, like some people predicted, relative, to what was predicted in high-income countries, which was a decline. But there weren't many Google searches for a lot of these terms in sub-Saharan Africa, and so we didn't have enough search volume to be able to reproduce these results. Now, as time goes on, this isn't going to be as much of as a problem as, low and middle income countries get more digitized and more people go online. But at least currently, there may be some issues with suppressed data because of low search volumes. If you want to look at lots of searches and lots of timeframes over large geographic areas, it may be really tedious to do this manually. So for this paper, we actually downloaded 2,000 different time series of Google searches, which is kind of too much to do manually. So then you would have to use some sort of automated package like R or Python to do this. And Google will actually limit you to only 1,000 requests a day. So it took us 2 days to do this, even though we had it automated. So that would take a little bit of technical expertise, but luckily a lot of these programs are freely available online. Okay, so I'm actually a few minutes over, so I'm going to wrap up now, but thank you very much. And I look forward to hearing your comments in the question and answer session.
Thank you, Dr. Wilde. And there is a quick question, which you may have just answered in things to consider, but Alejandro Ome had asked whether these were state level data.
So many countries have finer geographic regions in the country level. That depends on the country. So in the US, you can get metropolitan level data. So you could look at the greater New York City area You could also look at New York State, but in some countries, it's only the country, and for other countries, it's only the country and the first sub-national geographic unit.
Great, thank you. So moving on to our third and final speaker today, Dr. Diego Alburez is also at the Max Planck Institute for Demographic Research, where he heads the Kinship Inequalities Research Group, which he established with an award from the Max Planck Society last year. Dr. Alburez is best known for his work combining formal demography with innovative data sources. He's a recipient of multiple awards given to young researchers, including the British Society for Population Studies Early Career Award. His work has appeared in the Proceedings of the National Academy of Sciences, Demography, Population Development Review, and other key journals. Dr. Alburez received his PhD in Demography and Population Studies from the London School of Economics and Political Science in 2018. And today he'll present research that used daily mobility data from Google along with mortality and population data in England and Wales before and during the COVID pandemic to assess the effects of reduced human mobility on excess mortality. Dr. Alburez.
Yes, hi, Jeffrey and everyone. Thank you for the introduction and for the invitation to present here. And also thanks to Toshiko for all the great coordination. So the work that I will present, I'm actually quite happy to be presenting after Josh, because many of the things that he mentioned about the Google data also apply to the type of data that I will be discussing. And actually, I think that this is sort of a mirror study to the one that Josh presented, in the sense that Josh was using Google search data, and we will be using Google mobility data. Josh was looking at fertility, and we will be discussing mortality in the next 10-15 minutes. So this is work conducted in a team and led by my colleague Ugo Filippo Basellini, who is based at the Max Planck Institute as well. And to give you a brief overview about the study and what we wanted to achieve, so you have to kind of travel back in time to January 2020, when vaccines were not available, and one of the only tools in the arsenal of policymakers and governments were non-pharmaceutical interventions to contain the spread of COVID-19, in particular the restrictions on mobility. So we started this project around July 2020, and by that time so there was enough time had passed from the start of the pandemic that we already had some data that we could use to approach this problem that we faced, which was the question of the effectiveness of the NPIs, the non-pharmaceutical interventions, for reducing the mortality burden associated with the pandemic. And so some time had elapsed, but not enough that traditional data sources could give us a sense of how people's behaviors had changed in terms of how they were moving. So we looked at the available data, and we chose to focus on this association between excess mortality and human mobility at the regional level in England and Wales, covering the period between February and August 2020. Right, so that was our goal, and this is if you're interested in the details, I can send the link later to this paper. And to give you a sense of what the kind of data that we had. So on the one hand, we had traditional data that mortality researchers rely on, in this case coming from the Office of National Statistics of the UK. And these are weekly deaths registered in different regions. So for the presentation, I will speak about London, but we had this for other regions of England and Wales. So here you see this sort of seasonal pattern of deaths that is well known. And the start of the COVID-19 pandemic, we see this spike, which so we summarize in the way that demographers do as excess mortality, which is the levels of mortality that go beyond what we would expect if sort of the mortality trends followed the this seasonal pattern that we had observed in previous years, right? So COVID-19 associated with a high degree of excess mortality. And so that's what we have on one side of the equation. And then on the other side, we want to know how this is associated with the degree to which people were moving and the changes that happened to this movement. And this is where the online data comes from. So we use data from Google, so the so-called Google Community Reports, which you can still access using this link, or you just Google. You just search for Google mobility, and what this is so when users have not opted out from Google Map location history, so that which is the default. So most users will not have opted out. If you have Google Maps in your phone, then Google is tracking your movements, and when the pandemic started, then Google took this data, anonymized it, aggregated it, and produced data on how people were moving in different parts of the world at the regional level for all countries. Well, I think not all countries, but sort of all countries where Google operates. And here you can download the data. So if you download the data, it's a CSV file. It can be quite big, like 80 megabytes, but it's nothing that a normal computer can't manage, and it's not individual level data, right? So that's important to know. It's aggregate data, and I will show you what it looks like. And this is, of course, very important to note also. Google has discontinued the production of this type of information in October last year, right? So you can still access the previous data, but no new data is being released. I will come back to this in my discussion. So basically, this is what the data looks like. So Google distinguishes different types of movements. For example, movements that happen in the context of groceries. So people go into grocery stores. So in this case, you have time in the x-axis, so weeks in 2020, which correspond to starting the 15th of February up to 13th of March. And these are two different types of movements. These are grocery, and this is time spent at home. And this is percent change relative to a baseline, so the starting point. And here you can see as we start 2022, there's an increase in the movement to groceries, and sort of decrease and increase in the time that people spend at home. In March 12th, the government encourages social distancing. We see a rise in the movement to groceries, and also in the time that people spend at home. March 24th, a lockdown is enforced, and we see a radical decline in mobility for grocers in this case, and an increase in people staying at home, which is what we would expect. And then things kind of develop over time. So Google provides this information of mobility for different types of movements. So retail, parks, residential, workplaces. And what we did for this study is we just combined all of those. I can say more about that if you want, just into a single index, which here is at the regional level. That sort of says something about mobility. So to move on a bit about, so what we did then is we combined on the one hand, the excess mortality, the red line, how it developed over time. So the x-axis here is time. For the red line, the vertical axis is excess mortality. And for the blue line is changes in mobility, right? Because we wanted to know if there was an association between basically a reduction in mobility and a reduction in deaths from the pandemic, so excess mortality. And I'm not going to go into the technical details of the results, but one analysis that we did to kind of convey this message better of the type of results that we found is this counterfactual analysis, where we ask if these mobility restrictions had not happened at the time when they did, how many more deaths would have happened, right? So we assume that mobility never went down, and we fit our model to this counterfactual mobility scenario. So what does this scenario look like? You remember this change in mobility. So basically, we assume that that mobility just stayed constant at this level, right? So mobility never went down in this sort of imaginary world. And then what we do is that we see this is the sort of the real levels of excess mortality that we observe. And this is the excess mortality that we would have observed in this imaginary world in which the mobility restrictions were never enforced in the population. And for the case of London, we find that the difference between the number of deaths that are associated to this line and to this lower line is 22,000 deaths just for the region of London in the period that we consider. And then if we kind of extend it to the other regions of England and Wales, and you can just focus on this last row of totals and these columns of deaths averted. So we find that around 94,000 deaths were averted thanks to the introduction of the mobility restrictions. So in short, what we find is a robust association between reductions in mobility as measured by the Google data and excess mortality as measured by the data from the Office for National Statistics, right? So we're combining these two data sets. Around 94,000 deaths would have occurred if the mobility had not declined. And without mobility reductions, we would have seen around twice as many deaths as we saw in the real world. So our analysis is reproducible. If people from data to the final tables. So if people are interested in seeing that, this is the link. Happy to share it also afterwards. And so I want to conclude my presentation with some also reflection on this, what we learned from using this Google data. So some of the pros and some of the cons of relying on this type of data. So the pros is that it's very easy to use, zero cost, right? Because you just go to the website, you download the CSV file, and it has all been pre-processed by Google. It's in a standard format. You can just work with it with a normal computer. You can open it in Excel. And it provides relatively real-time mobility data. So when it was updated regularly, so that you had data that was up to date. And in this case, it showed movement by type of mobility, which can be interesting for some types of analysis. It's free, not for researchers, not just to researchers, but to everyone. And it's also comparable within a national territory, so regions within a given country, or also internationally, which is a big advantage. Now, some of the cons is that the information that Google has and shares depends on who uses the product. And we know that the distribution of users does not necessarily represent the distribution of the real population. So people who are older or members of disadvantaged groups may be less represented in the data. They may also be at a higher risk of dying because of the pandemic. We also don't have individual level data, right? So because of privacy reasons, Google does not share this type of data. We only have aggregate data. And what I think is one of the biggest challenges of using this type of data is that we rely on the kindness of strangers. And in this particular case, the stranger is Google, and we rely on Google making this data available to us, and they can just choose to not make it available at any point, like happened in October last year with this mobility data, right? So they do it out of the goodness of their heart, and there is makes it very difficult for researchers to plan, look into to plan ahead because we don't know if the data is going to be available. And then another big challenge is we don't really know what's happening inside this black box that is Google. So there are no detailed reports. There is some information about the methods, but it's not enough to know how the data, how we go from individuals having a mobile phone with a Google Maps installed to the CSV file that we obtain. And it can be that Google changes the way in which it processes the data over time. So the algorithm drifts, and we don't know about them. So I will finish with that, and I look forward to the discussion.
Thank you, Dr. Alvarez. At this point, I'd like to invite Toshiko Kaneda to rejoin the team and to lead the discussion period. And Toshiko, kudos, because I see your work and your fingers in having put this together and having worked with the team so that we got very precise and great presentations, but still have time to actually discuss them, which a lot of times in these we don't. So thank you, Toshiko, and thank you to our presenters. And so Toshiko, over to you.
Yes, thank you, Jeff. And thank you to all the presenters for very insightful, interesting studies. Now I would like to open the floor for questions that audiences may have. If you will, let me just make sure I have. Please raise your hand and I'll call your name. Tom, please go ahead. You can just unmute yourself.
Okay, thank you. Can you hear me? All right.
Yes.
I don't know if it's a question or a comment. I'd just like to throw it open to the presenters. Myself, I'm very interested in using new data, new approaches for the analysis of relatively small areas in sub-Saharan Africa. And that sounds like a fairly difficult thing to do, even with these data. It seems to me that you've got access to new data that is changing very fast. Google seems to be very good, but as you said, the algorithms are hidden and everything's aggregate. Facebook, it's only kind of very aggregate data. It's not individual data whatsoever. There's a lot of data that is very important that you can't get access to: credit card data, pharmacy data, et cetera, which, some people working with big data, they want to see changes in demand for certain medicines. You can't get that directly, even though that data does exist. It's just inaccessible, or it's largely inaccessible. And then on the other hand, you need to link this data to more standard types of data. And I think all the linkages you can do, if I'm right, are kind of at the aggregate zone level area. So that really, perhaps the Google data, whatever, you could use as a contextual variable if you're using DHS data or census data or something else for the analysis. But I think there's a lot of change in that level too. DHS is now using geocodes. EPUMS is starting to have geographically defined data on their data set, on their website. There's satellite data, which often isn't integrated. And am I right? These are the big issues: is accessibility to some of the big new sources of data, and then the linkage to sources of data that, as social sciences, we need to have if we're going to do anything beyond just description.
Thank you, Tom. Would any of the presenters like to respond to that? Very interesting and important questions for us.
Yeah, I'll just say that I agree. So, when I was in grad school, I would always hear something like, well, we're using this data to answer this question, but the data wasn't collected with this question in mind. It was collected with another question in mind, so it's not perfect. That's exactly what's happening with this digital data. So these are firms who are trying to sell products, who are trying to make a profit. They're not really thinking about necessarily data when they are collecting this, this data. And as Diego said, we're kind of just relying on their, their kindness to provide this data to us. And so, these data companies, they have an incentive to hide data, and for privacy reasons, right? So it's the privacy versus the accessibility issue here. So they don't necessarily want to share individual data, but researchers want individual data, and so there's a tension. And we're relying on their kindness, and we can't constrain them to give data. And even if we could constrain them, then there's the philosophical question of whether that's an ethical or a good thing to do in the first place. So these are the big tensions. One of the big comments I got on my paper was, oh, how is the effect heterogeneous for low income individuals versus high income individuals? And I had to say, I have no idea. I could stratify the dependent variable. I could look at like births to low income individuals if the CDC gave that to me, but I couldn't look at how searches were different by these different groups. So anyways, this is just a long-winded way of me saying that, yes, you've hit on very important topics that are being discussed kind of at this high-level philosophical level, but we don't have the data necessarily that we would want at this point at the individual level for these types of analyses.
So I can just add something too. So I agree with what Josh said. And I think the challenge, like some people have had access to this type of data. I think Social Science One was, or is, an initiative where people could access individual level data from Facebook under sort of like highly controlled, because you also have settings, because you have the issue of privacy, right, that you want to keep front and center. So one solution, or like a promising direction that I see efforts going, is in developing sort of standardized protocols to allow researchers to access the data from the platforms without relying on their kindness, right? So we don't wait until Google creates this website where they give the information, but there are sort of specific APIs that researchers who have been vetted can use to, I think they call it sending the code to the data, right? So that you actually send the request and then you get the thing back in a standardized way. So I think that's something and that is maybe useful moving forward.
I'd like to comment. Thank you. I'd like to comment as well, because first of all, Thomas, you brought up an issue, and that's that the algorithms are a black box. So we don't know exactly how they're estimated. And I think that's a limitation we have. And also because there's no historical of it. So it's not like I can go back. I have whatever I downloaded, but it's difficult to reproduce it in terms of putting it publicly to reproduce the data that was downloaded at that given moment from Google. Now they charge about 0.8 for what we did, 0.8 cents per measurement. And what we did do was they offer a sample kind of thing, like so that you get a taster of how this works. And because we were a large group, we put together our samples, and that's how we were able to measure the 2 weeks without having to have a grant to support that. The rest was in-kind contributions that we received from our co-authors. So I just wanted to point that out of how we can access that and work on a shoestring.
Thank you. Anyone else would like to add to the point or ask any additional questions? Or maybe the presenters would like to raise some issues.
I think that in measuring using the Google data, by going to the level of traffic analysis zones, you lose a little bit of precision because the census gives you information at the block level. But for us, actually, it's good enough to come to the conclusions that we need to come, where to put the services and how it's affecting people, as you may have seen in the results. I don't think that's going to change dramatically by adding a little bit of, taking the precision from the 507 traffic analysis zones to 15,000 blocks. Actually, it helped us in a way because the questions that the ethics review committees have, and in the health sector, the ethics review committees are quite stringent, were about privacy. If it was possible to identify an individual by the information that we were making available, and by going to the traffic analysis zones, which is broader but still granular enough, I think we brought down the barriers because it became very difficult to identify an individual.
Great point. Thanks for mentioning that. Okay, now I'd like to go to Janet. Please unmute yourself. Janet, I see your hands up. If you're not able to unmute yourself, maybe you can type up your questions and we'll be happy to read it. So while waiting for Janet, anyone else like to ask questions?
Toshiko Marlene put a question in the chat. I'll read it. She said, sorry, I cannot speak due to throat issues. Do any of the speakers know about readily accessible algorithms that would allow researchers to collaborate with companies on anonymizing or preparing data for research use? This may be what Dr. Alburez mentioned.
Yeah, so I can say, so I know, so the question I think is not about algorithms, because the algorithms are not difficult to produce, right? So any engineer could write an algorithm that connects to an API and retrieves data. I think what are needed are institutional agreements between companies and governments, universities, in which the companies themselves commit to allowing researchers to access the information. So I know that there is, I can't remember the name, I was trying to find it now, but there is one framework that is lobbying for this type of systems to be established, where companies make accessible the data in a secure environment and then researchers access it. I'll try to remember the name and send it to the chat.
Great.
But I would say it's not a technical problem. I don't think so. This is the thing, like it's not about like complex algorithms, it's about political will.
Thank you, Diego. Marin, I hope it addressed your question, but if not, type another question in the chat. And I'm sorry, I know I missed the comment by Janet earlier about the point that we were talking about. What it does do is bring questions to communities, decision makers, which could force more investigation and interest or advocacy on the issue. Great point. Thank you. Janet, if you'd like to add more to that point, please feel free to type in or unmute yourself. Anyone else with any questions? Yes. I see Tom's hand up again. Please unmute yourself.
Sorry, I wasn't going to talk, but nobody else is raising their hand.
Please do.
Years ago, I worked in Australia, and they had a fairly strange way of handling confidentiality with census data. And they created a very large sample, and researchers could access over the web that sample. But they couldn't access the sample per se. They could send in like a data program. And it was made so it would not allow you to do things which were very annoying. You couldn't do something and do a list of several observations to see if your program was working right, because they would not let you see any individual data. But you could get results like regression coefficients, which meant that you could actually do individual level analysis. You could just not see the individual data. And I'm wondering if that sort of thing is being discussed. I know this would be expensive for Google, but a lot of these, the owners of these companies want to show that they are being good moral citizens, and they might be willing to do this. Is there any discussion of making that sort of access available, which would be of enormous value to researchers?
So I think that's exactly what I was thinking about, and that it exists. So I know that Facebook, for example, I think it was in the context of Social Science 1, had a similar system, where I think there was something like privacy points that you get like a certain amount of points, and each operation has a cost. Like if you want to do like a mean of something that costs a certain number of points, and the idea is sort of to protect privacy, and then like you can plan your analysis around that. And I would just repeat what I said, that I think it's not a technical problem. Like people who use register data, people who use census, like these already exist in systems where you can access things remotely and just send the code. I think it's just a question of political will.
Yeah, and I'll just reiterate the point that Diego just made, especially in the context of register data. So, at Max Planck, there's a lot of people who work with Nordic register data, and it's the same way. You send them code and they send you back results because you can't see anything. They have a little bit more of an incentive to collaborate. They're not a profit maximizing organization. They're a government agency, and they kind of are more kind of open to this data being used as long as the privacy is preserved. I think what needs to happen is you have to make some sort of argument like you were making, like we can advertise that we're good public citizens, or something that is in the company's incentive to kind of allow researchers to come in. And some companies are better at this than others. So, Facebook, I think they get a lot of good press for the fact that they allow, at least on a broad level, their data to be used. I also know there's a lot of companies that do this all in-house. So they don't like outside researchers to do this analysis, but they are very happy to do it inside their company, because then they get to write interesting blog posts. So I study fertility. There are a lot of dating apps, for example, that like to publish, if you put this in your profile, then you get X% more hits or likes or whatever. And every so often, they will publish these interesting research articles that might be something that a researcher could have done or be interested in doing, but they do it, and it's a way of generating like interesting traffic to their site. So I guess, as Diego has said many times, what we need to do is figure out a way to get not just in-house people, but kind of outside researchers to get access to this data. Perhaps, saying, if you let me have this data, then maybe I will do some of these analyses that you were going to do anyways, make an incentive for them to want to allow outside researchers to access the data.
Tashiko, I'm unmuted. It's Jan Hatcher Roberts. I got unmuted. I don't know what's going.
Great.
So, but I cannot unmute or do my video. I have no idea what's going on.
No
Anyway,
problem. We hear you clearly.
I did want to add to my comment, and because I'm a co-author with Luis, and really have really enjoyed this presentation. We were meeting on Saturday because I work with our electoral district, and we're all ready for a snap election in Canada all the time. So we're preparing local level data analysis, and we have some wonderful people from our Statistics Canada group, etc. But this strikes me as the work that you could put out to ask questions for advocacy, for getting people interested in moving into more research. It's not as we think, it's not individual data, we don't have enough sample size, but what it does do is kind of move people to start thinking about associations, inequities, and perhaps asking more questions. So I think it's really useful, all of the presentations for us who want to do some advocacy at a level that maybe we never did before when we were working full time. So I find it very exciting. So thank you. And sorry, I couldn't figure this out. I have no idea. I kept going on to pictures of my grandchildren, which I'm sure you did.
That would have been lovely too. Thank you, Janet, for sharing that.
I can't lower my hand. I have no idea what's going on.
No worries. Good.
Sorry. Okay.
Thank you. Great comments. And Luis, Gabriel, I think I saw your hands up first, and then we go to Jeff.
Okay, well, very quickly, just to mention that when we started our project, we reached out to Google to see if we could get a grant or a support or a quota of data downloads that could be free, and we couldn't get it. So basically what we ended up using is they have free samples. That's what they offer. And because we were a large group, we put all free samples together, and that's what we used. So just to say that, and in our situation, because I work for an intergovernmental organization, actually receiving money is an issue. It would be very difficult to manage. So we were able to do this on a shoestring. Actually, became more convenient to not receive monies. We could have received the samples, but that didn't happen. Google was interested in how we managed to do it because, as you saw, the price would have been about $3.5 million for each of the weeks we sampled. But it was through the data sciences that we managed working with Equatio to make this doable. So just to make that clarification.
Really interesting to learn. Thank you. Now we'll go to Jeff.
Just a question that might close this out, but for each of the researchers, these were tremendous presentations. Based on what you learned about the use of the data that you've got in yours, the question either is, what might you have changed in stepping into it based on what you know now, and or what's next? What's your, based on what you've just done, do you already have in process or plans that you can share that are impacting your future research? Thanks.
So I'll start.
Like to go first. Yes.
Yeah. Yeah. So when I started this project, I think I was starry-eyed a little bit about the potential of these kind of online big data sources to, solve all the problems that traditional researchers have with not being able to get data. But the more that I, got into it, I realized that these online digital sources are useful for certain questions, but as we've been mentioning before, they have significant limitations. So I think I mentioned that I, at one point, started a project where I was going to basically reproduce what I did in the US for sub-Saharan Africa, and then basically wasn't able to do it because too much data was being suppressed for privacy reasons on the Google side. So, I think Tom Legrand's question or comment about, how to get more access in the future. I think this is a big, important margin that the field needs to move forward on to be able to make data more accessible. Regarding future projects, I do have one project with some people also at Max Planck, where we are trying to address the question of how climate change might affect fertility. And so what we're doing is we're linking these Google search terms in the US, rather than linking them with birth outcomes later, as we did in the COVID pandemic, we're actually linking them with temperatures. So we're seeing how temperatures change Google traffic. And then we're trying to use those changes in Google traffic for mate seeking, online dating, these other types of questions to see how climate change could be affecting these behaviors that could then affect fertility. But again, it's in the US, there's a lot of data there. I'm kind of sad about the amount of data available for Google search terms in low and middle income countries, just because Google suppresses a lot of it. So it's a great data source for certain types of questions, but there are significant limitations.
Hopefully the situation in low and middle income countries will also change, improve. Quickly, let's go to the other two presenters if you'd like to share about your plans for the future. Luis, Gabriel, would you like to go first?
Yes. Okay, yes. Well, three things. One, we want to integrate the data with land use planning and health services planning. And the way we're doing it is that actually the key stakeholders in this process, whether it's authorities, consumers like health services providers and health services users, or people from the community, are involved from the outset. So I think that's one thing. We want them to use the data for advocacy, the observatories, the urban observatories, and so on. And we have the plan to measure if that is actually happening. So Carmen Villamizar, who just joined, her master's dissertation is going to be about the use of the data by the key stakeholders. We want to replicate to see if this works in other places. So we actually have been in communication with partners in sub-Saharan Africa that actually Google introduced us to, who might be interested. Currently, they were measuring accessibility to health services by putting someone with a chronometer in the car, taking the person to the hospital. And that was with a small sample. Here, you're using millions of observations, so that's much more precise, and we want to replicate that. It probably is going to be easier in Latin America than in Sub-Saharan Africa because there's more countries that already have digitized data. And that makes it so much easier. Like, for example, in Colombia, you could do it anywhere. And we would prioritize cities where there's substantial traffic because that's where this makes a difference. So that's the integration with the plans, the replication, and how this is used are the three elements that we have in our plans ahead.
Right, thank you. Now, Diego.
Yeah, so in terms of future plans, I think also expanding this analysis to other countries, especially now that better data has become available, to see the effect of mobility restrictions on excess mortality in other countries, I think is something that would be very interesting. And the other thing is also using the platforms to collect data in a more proactive way, sort of asking people questions on platforms by using advertisement platforms. So within the Facebook or whichever platform it is, sort of using their own ads to ask people questions. I think it's something that is has a lot of uses for also sort of checking what we get from the aggregate data with individual level data, but also going beyond that.
Thank you, Diego. So lots of exciting plans ahead. Anyone else for the last questions? And welcome, Carmen. If no more questions, then I would like to wrap up this seminar. So despite all the limitations, I think having access to big data at no cost or low cost has certainly, I think we all agree, has certainly opened an important avenue for us to address new questions and also address old questions in new ways. In our population bulletin that Jeff mentioned about earlier, we do talk about the importance of building communities of diverse actors, including data producers and data users, data analysts and policymakers, bring them all together to make most use of what we can get from big data in identifying and addressing important issues. And the point was also raised by Louis, Gabriel, and others here. So I think it's very important, and we really like to encourage you all to build or support building such communities so we can leverage what big data has to offer to advance our field and really also to ultimately improve the well-being of people around the world. I hope you will check out the studies by these authors. I dropped the links in the chat, and also please check out our population bulletin if you haven't already. And with that, I'd like to conclude this PRB demography talk.